Good morning. My name is Margaret Rosenzweig. On behalf of Dr. Lynn Robertson and myself, we are pleased to present to you the Hillman Cancer Center's plan for community outreach and engagement. Dr. Robertson and I share leadership in this endeavor. We work closely and collaboratively with two distinct areas of responsibility. Dr. Robertson is the Associate Director for Catchment Area Outreach and Engagement. She directs the Office for Health Equity, Education, and Advocacy and works closely with community and state agencies for cancer control. I'm the Associate Director for Catchment Research. I'm responsible for the development and coordination of research around our identified catchment area burdens. The leadership of COE efforts includes the Committee for Health Equity and Community Outreach and Engagement, or CHECO, established in 2013. The committee includes representation from the Behavioral Cancer Program, Hillman and Research Administration, as well as surgery, policy expertise, and basic and population sciences. The Community Advisory Board for the COE consists of 10 external individuals known for their patient advocacy, survivorship voice, and community presence. The CAB meets at least quarterly or more often as needed. The process by which COE initiatives are implemented is outlined here. Drs. Robertson, myself, Jianmin Wan, and others compile and analyze data from multiple sources. We then present these data for prioritization and implementation decisions to CHECO and the Community Advisory Board. The resultant action and evaluation plans are then shared with OHEEA for outreach and with the REAC, or Research Executive Advisory Committee, for research endeavors. This process then guides us, in harmony with the mission and strategic plan of the Hillman Cancer Center, to implement the following aims: to monitor the cancer burdens of the Hillman Cancer Center, to implement evidence-based community interventions, to promote, inform, and enhance catchment area research and use that research to influence policy, and to ensure equitable cancer care to all members of the population. The first aim is to identify and monitor the cancer burdens of the Hillman Cancer Center in order to establish our priorities. As presented in the Director's overview, the catchment area is represented by 29 counties, population of a little over 4 million people, 51% female, 50% rural with 18.2% of the population over age 65. The population is largely white, with Blacks the largest minority population at 6.4% and the Hispanic population at 1.4%. Accrual to interventional trials for Black patients has been stable and representative of the population at 5%. Based on 2012-16 PA Cancer Registry data, overall 25 of the 29 catchment area counties represented in green have higher incident rates than U.S. average, represented in pink. The highest incident rates in our catchment area are female breast, prostate, lung, colorectal. We also note higher than national averages in our catchment area for melanoma, thyroid, and pancreatic cancers. Mortality rates are slightly larger than U.S. rates, and our primary mortality rates are lung, female breast, prostate, colorectal, and pancreatic cancers. As we continue to assess the catchment area to establish priorities, we note racial disparity in both incidence and mortality. There are higher incident rates of prostate, lung, and pancreatic cancers, and higher mortality rates for Black patients for lung, female breast, prostate, colorectal, and pancreatic cancers. To establish priorities, the community and patient voice is of vital importance. Data from the P30 CCSG supplement demonstrated areas of actionable community vulnerability, including high tobacco use and poor colorectal and mammography screening. The 2017 PA Behavioral Risk Survey indicated that lack of knowledge or confusion around screening was correlated to poor screening behaviors. An additional CCSG supplement explicated actionable targets that are barriers to HPV vaccine uptake, including important differences between rural and urban clinicians' HPV vaccine knowledge and beliefs. These data and others then collectively inform the prioritization process and the direction and mandates for the Hillman Cancer Center Plan for Outreach, Engagement, and Research. The established priorities were determined to be to address cancers of high incidence and mortality with attention to racial disparity, to improve screening rates for breast and CRC cancers, although stable, improve minority inclusion in clinical trials, increase HPV vaccine uptake, and better understand the cancer risks and vulnerabilities posed by demographics and community. For AIM 2, there are many active community outreach and engagement initiatives to address the Hillman Cancer Center prioritized burdens. This outreach is made possible through Dr. Robertson's OHEEA staff of nurse practitioners, cancer educators, and tobacco cessation counselors. In partnership with multiple agencies, this office impacts literally thousands of individuals throughout Western Pennsylvania through community events, wellness fairs, and in the school through Healthy Choices curriculum. Patients are also screened and, if necessary, navigated to and through cancer treatment, with potential for clinical trial access. Community engagement exemplar resulting in excellent cancer outcomes for underserved populations is seen through the partnership with Hillman's OHEAA staff, the Birmingham Free Clinic in Pittsburgh, Southside, and Adagio Health, the local administrators of the Breast and Cervical Prevention and Treatment Program. Through counseling and navigation, the OHEAA office in 2 years has provided screening to 250 largely minority women for breast and cervical screening, resulting in 6 cancer diagnoses. Through partnership with UPMC Philanthropy and Dr. Rocky Schoen, a Hillman investigator and NCI Early Detection Research Network investigator, at the same clinic, within those same 2 years, the OHEEA office provided colon screening to 10,020 individuals, with 62 patients subsequently navigated to largely no-cost colonoscopy and 62 precancerous polyps removed. For AIM 3, the COE is responsible for the engagement of research directed at the Hillman Cancer Center burdens. Additional details for each program's research efforts that address the burdens can be found in the individual write-ups and in subsequent presentations. My responsibility is to catalyze research to address the catchment area burdens. I work closely with the development of the targeted pilot research funds supported through CCSG and the Hillman Developmental Funds. 3 examples of the 6 funded pilot projects targeting COE includes Dr. Brusky's and my program testing a telemedicine program to ensure that patients in rural Pennsylvania have access to genetic testing. Dr. Sabik and Schenker are studying the role of the opiate crisis, which is particularly acute in Western PA, on oncologist prescribing practices. And Dr. Chu, who is a social media researcher, is piloting a novel program of utilizing student leaders to combat the vaping and tobacco crisis in Western PA middle and high schools. A component of AIM 3 is also to utilize this important research to influence policy around cancer burdens. The Hillman Cancer Center influences policy through strong partnerships with governmental agencies. A particularly compelling example has been that Hillman expertise and advocacy was instrumental in passing Article 22 from the Allegheny County Council, a 2017 ban on e-cigarette use in public places. Dr. Robertson works closely with statewide designated cancer centers to increase HPV vaccine reporting and in other cancer control initiatives statewide. An additional example of policy influence is Dr. Wendy Berg's efforts to expand coverage for dense breast assessment to include 3D mammography. Dr. Berg shares her research findings with key breast cancer advocates who in turn influence PA state legislators. As a result, PA was the first state to expand mammography coverage to include 3D mammography. AIM 4 is to ensure access to all patients to state-of-the-art cancer care. Dr. Robertson's work with the ACCURE study demonstrated that a 2-pronged approach of provider bias training and patient navigation equalized disparity in breast and lung treatment completion rates. Because of these successful findings, the provider bias training has now been implemented into onboarding for all Hillman Cancer Center employees. In order to ensure state-of-the-art cancer care to all catchment area residents, we increased attention to minority recruitment to clinical trials. We have added 2 minority-focused ambassadors, a Hispanic navigator, and minority research coordinators in clinics serving Black communities. In addition, surgeon and Chico committee member, Dr. Steve Evans, is leading a task force towards breast cancer awareness and clinical trial recruitment in the McKeesport area. We have many plans for the next few years. We have submitted an R13 application to support a Western PA Cancer Health Equity Conference to be held in September 2020. To continue to address our priorities, we will strengthen our outreach to underserved Pittsburgh neighborhoods through the new University of Pittsburgh's community engagement centers and access to immigrant populations through Catholic Charities. For rural communities, we will utilize our extensive clinical network for community anchors as we provide education and navigation around risk factors and screenings. We are partnering with Pitt's CTSI and All of Us recruitment for access to housing projects throughout Pittsburgh's Housing Authority. We will continue our statewide work for facilitating and tracking HPV vaccine. We will continue to work and navigate community members and patients for tobacco cessation. In fact, this is a goal of our Community Advisory Board to host a community tobacco summit, and we will assist them in this endeavor in this upcoming year. Taking advantage of our economic and potential environmental risks in neighborhoods throughout the catchment area, we will facilitate pilot work around models of environmental risk on cancer incidence and outcomes. And of course, we will continue to mentor students and researchers interested in community engagement and research. Thank you for the opportunity to present the COE plan for the Hillman Cancer Center.
Dr. Rebeck.
Thanks. I have 3 questions for you. First of all, you're monitoring the cancer burden AIM-1. Could you provide a little bit more information about where your numbers come from? I tried to go to the web and find those same numbers, and I couldn't replicate them. And it looks like you're using the numbers for Allegheny County, or is it the whole catchment area? Could you just clarify how you get as you're prioritizing and monitoring, how you've done that?
We do a combination of monitoring. So we use the statewide EDDI system, and then we do use Allegheny County systems. We can go to individual counties as they are provided and get individual numbers that way.
So the numbers that you presented are for either the state or Allegheny, not the catchment area per se, the counties in your catchment area?
I believe they are for our catchment area.
Directly for our catchment area.
Okay, well, I couldn't
Calculated as per county.
Okay, yep. I couldn't replicate that, so it'd be good. So while you're making the choices, you have a lot of information you've put in, and you've given a lot of priorities that are outlined, but they're quite broad. You know, it's like most of the cancers, most of the mortality, disparities, it's many things. As you're thinking about the priorities, how do you actually decide what comes to the top that you spend your energy on in identifying those priorities that you work on to develop the research? And related to that question is how the community is involved in those decisions. I know you presented some stuff about that. You have a community advisory board, and you had the moonshot summits and things like that, but how do they actually feed into deciding what really the top priorities are for your work?
What we do is actually bring the incidence and mortality data as well as the disparity data to the Community Advisory Board. And then through that, I mean, they can see which the top with lung, breast, et cetera. So then they help us to formulate, in addition to our strategic planning for the whole cancer center, formulate what are the top priorities and which we should tackle first. For instance, seeing lung cancer was a big incidence and mortality cancer. They really centered in on tobacco cessation and doing something around that as one of the top priorities.
And so they, do they just have things they bring to you as opposed to you, I mean that?
No, we share the data, we share our strategic plan, and then they give us feedback, and it's didactic.
Okay. So then the sort of last thing is the major goal of the COE in the FOA description is to facilitate research. That's really what you're about. And so the examples of implementation of interventions is fine, but that's not really what the COE is supposed to be doing necessarily. That's not the main thing. The main thing, I think, is to facilitate research. And so it wasn't clear in the examples that you gave, and even in the write-up, what you do to facilitate research by Hillman investigators that impacts on the catchment area. So as examples, there were lots of examples of science that are relevant, but they're examples of science that didn't really talk about what the COE, the CHICO, is doing. And similarly, you know, the examples that you did give were like opioids, e-cigarettes, genetic testing, distance learning, which weren't part of your priorities, weren't, or I didn't see were part of the priorities that you engaged in. So can you talk about, you've identified priorities and you're facilitating research. Are there examples of where you've actually taken the priorities and facilitated research in the catchment area?
Right, so when we work through the REACT committee to present the priorities and then say to each, my responsibility is to say with each individual program, here are the priorities. Can we look at your research portfolio and what are ways that that can be expanded to perhaps capture these priorities more specifically or that really work for our catchment area. So I think that this process is working, and I see that this is the process going forward that will be really instrumental in moving everybody together. The ability to impact the pilot programs has been really beneficial because we can continue to work with those investigators and then grow those into larger projects. So I feel like it is working. It's a process of knowing everybody's research portfolio and seeing where their particular projects fit in, and then how can we develop them within each program.
Can you give an example of one of those successes of that process?
In the breast program, we have been working on individual programs for addressing the racial disparity in breast cancer. And so in working with Steffi Ostrick and Adrian Lee, we started to think about the possible metabolomics of Black women as they're receiving chemotherapy and experience symptom distress. And so we were able to develop a pilot project from that in order to measure metabolomics of Black women's, essentially taxanes, and that has been funded. So it was directly as a result of seeing this disparity, working with them, and then being able to write the research and get that funded.
Great, thank you.
Yeah, I thought that was a great example. I think you should try to present something like that. I think I agree with Tim, like your previous slide with your future plans is 85% is outreach and a tiny bit at the bottom on research. And that's not the message you want to leave.
Okay.
And the other point is that you're proposing this new population survey facility, which is directly relevant, but you didn't mention at all. This needs to be part of your presentation, at least as part of future plans.
Right. We should have.
So, oh, I'm sorry. Go ahead, Kathy.
Kind of drilling down a little on your priorities. How do your priorities fit with the Cancer Center strategic vision through 2023?
They really dovetail with them. I mean, we very much, look at our strategic plan and the priorities for the Cancer Center, and then work with those for community outreach and engagement, as well as our research.
So I noticed in them that there is an emphasis on environment and aging, and I didn't see examples around that and how you're bringing that into the priorities and promoting those.
So we work with the aging group to think about research priorities. Many of the programs will present research addressing aging, and so we feel like that is it's something that should be fostered. So we can mention that in our research, addressing that, catalyzing research to address that impact. The environmental risk we could get to through the population survey, and really understanding these neighborhoods better is a big research goal and priority. The environmental risk, the toxicity that individual neighborhoods may possess in terms of cancer incident and outcome is very interesting, and I think does address, not only presents great research opportunities, but does address the cancer, all of our COE needs.
And we do sit on those strategic teams too. So we plan and work with the aging as well as the environment and cancer.
You seem in your priorities to stress screening, particularly of two of your major cancers. But you didn't give any metrics around that. That is, what are the screening rates now, and do you have goals around where you hope to go to and how you'll get there?
Well, we could certainly add the metrics to that within our slide presentation.
Right, so I'm asking I'm making comment as an EAB member, not a site visitor. I didn't, unfortunately, time you, but I'm pretty sure you went over the 10 minutes that were allocated. And in fact, 18 slides is way too many to try to cover in 10 minutes. However, this is such an important part of cancer center reviews now, and that it plays such a big role in how the site visitors view the whole cancer center. I think you're allowed to go 20 minutes on this presentation. And you might think about, instead of presenting developmental funds as a separate entity and just have one slide on developmental funds or return on investment in the director's overview, give 20 minutes to community outreach and engagement and really cover all the different components, because it's such an important part of the assessment. So just, because there's nothing that you covered that I thought you could take out. In fact, I was thinking about additional things you needed to add in, and you're just not going to be able to do that in 10 minutes. So just a suggestion, if I'd be interested what others have to say. We did 20 minutes for ours.
We did 14 for ours.
We did 20.
So Mike, if we go that route, we may want to get it in writing.
I'm sorry, you want that in writing?
We may want that in writing.
So, I mean, the NCI will allow you to change
You can change your
the
agenda.
schedule anytime up until the site visit. So it's not a problem from that perspective.
I heard they hired Gail Bryant back, so
Now you can change it.
Out of retirement.
Do others agree with that?
I completely agree with that.
Yeah.
This is such a critical thing, it deserves more time, and it's a lot to try to cram into 10 minutes.
Well, if
Yeah.
we have more time, I would not take out the community engagement, because I think it is very impressive, but certainly add the
Research.
specific research examples that we've had to cut.
Yeah, I think to Tim's point, though, what you really are going to have to focus on, how the Community Advisory Board, all of this in outreach and engagement actually informed your research priority, and then give a couple very crisp examples
Okay.
of what was the result of that. I mean, I think, take care of about 80% of the patients in this region. Those are the ones who are going to be the best. You have them captive for cessation. What are the research projects? What's your implementation science? Where is all of that? Those have to be front and center, because you're too big or breast and lung, right? So if you talked about a cessation summit in the community, well, what are you doing inpatient, outpatient here with people are at incredibly high risk and already have cancer? And how did all that loop occur? I think that's really got to be part of this time here.
And that would be more important than the pilots,
Correct.
which I don't think represented anything, the major goals of your catchment area. They're important, but somebody else presented them, so.
I think you want to pick like two of your priorities and walk us through. How did
Yes.
you think that through? What are the multiple things in the multiple programs that are moving on from even basic to translation?
Stories.
So
lead
yeah, so we
stories.
get a sense that we've identified these problems. Let's tell you about how we're accomplishing a focus on this problem. So go from the problem, tobacco or lung cancer or whatever, and walk us through how you're tackling that as a cancer center.
Okay, we can do that.
I think I would also emphasize the funded research with your slides, with your examples, because as an evidence that there is a lot of research
Yeah,
already.
we've gone back and
already
forth. Okay.
done.
You think the funding should be
I-
on the slides?
Absolutely,
Okay.
yeah. Or the grant number
Okay.
and the kind of grant. I guess the other thing is it would really help to have metrics and goals. That may be realistic in some cases, but not in others. But you can say we're going to take our 70% vaccination rate and make it 85% or whatever.
Okay.
And similarly, we're going to encounter, 20,000 people about smoking. Something, even if it's an aspirational goal, I think it would be helpful to show that you really are bought into the area. I had a couple of very, very small suggestions too. I think I wouldn't say you're applying for money to hold the symposium. I would say we are going to hold the symposium, and we'll figure out a way to pay for it, but we also are applying for NCI for funding. And I guess the other, female breast cancer obviously is only 1 percentage point off. And I wonder, that's an unusual designation, and that must relate somehow to your statistics that are available to you. But I think if you could simply make it breast cancer, that will not put people off.
I mean, to that point, I couldn't replicate your numbers. So if you get a really pointy-headed reviewer like me, you should just be really clear and maybe have some numbers handy, because it looked like some of your numbers were exactly Allegheny County. So
Okay.
hopefully you didn't just take Allegheny County, because that's what it looked like. And you just don't want to have that happen if somebody decides to be nitpicky, which we always do. Yeah.
Yeah, I don't know how the others on our committee feel, but, I think site visitors are expecting, when you open this presentation, to say what the problem is. And for you, that's slides 7 and 8. And there's a lot of process and pictures of people. I think you want to maybe move that part up and say, this is the catchment area, and this is where we see the needs of that catchment area that are distinct. And you have a challenge in that your incidence rates that you show on slide 8, don't differ dramatically from the national average. So you need to explain how you've chosen the priorities that we've been talking about from that. But I just think site visitors don't like surprises on the day of the site visit. So I might think about moving that earlier in the presentation. This is the problem, and this is what we're doing. Within that problem, or those problems, these are the ones we've chosen for our priorities. And then the research and the outreach that addresses those should flow from that.
One last just final thing, that when you talk about the interaction with the community, you have to make it really clear it's bi-directional. You talk to each other, but you said we bring the stats to them and then have them respond. Really, they just need to tell you what's important to them. It's very bi-directional. It's not, you shouldn't tell them what's important and then have them respond, which I know maybe not what you do, but that's the way it came across.
Thank you.
Bob, I know we're running a little late. I'm not worried about that at all, because we have a lot of time set aside for executive sessions. That's not going to be as important for today.
Good. Okay, thank you.